Part 3 of respiratory problems. Tuberculosis is an infection that's due to the Mycobacterium tuberculosis, which is an acid-fast bacillus that is transmitted airborne. You get an inflammatory response that engulfs the bacilli and prevents the spread by forming a tubercle, in which the bacteria die, causing a caseation necrosis, which is a walled-off area in the lungs, usually, by a collagenous scar tissue. That usually takes 2 to 3 weeks to occur. And so now you'll have a positive TB test. But it can lie dormant forever. Symptoms are you're asymptomatic until the disease is very advanced. You'll have fatigue, weight loss, lethargy, anorexia, low-grade fever, cough, night sweats, and anxiety. It can also cause bone pain, dyspnea, chest pain, hemoptysis, neurologic deficits, meningitis symptoms, and urinary symptoms, depending on how long they wait before they get treatment. There is an increased incidence in the homeless, those living in very crowded conditions, crowded institutional settings like extended care facilities, substance abuse, people who immigrate from high prevalence countries to here, third world nations, lack of access to medical care. Those patients who are immunocompromised or have a poor nutritional state, are type 1 diabetics, or use lots of steroids are also at risk. And this is showing from the memory book somebody who has TB. Characteristic: weakness, anorexia, weight loss, and night sweats with hemoptysis. Low-grade fever in the afternoon. These patients must be isolated, and you'll learn all about this when you get into adult health too. Pulmonary embolism is an occlusion due to an embolus, and 90% of them occur from a deep vein thrombosis. And this is showing deep vein thrombosis risk factors at the top: venostasis, vessel injury, hypercoagulability. Then you have thrombus formation, dislodgement of a portion of the thrombus, occlusion of part of that pulmonary circulation, hypoxic vasoconstriction, decreased surfactant, release of your neurohumoral substances, pulmonary edema and atelectasis, and then you get your symptoms of pulmonary edema, pulmonary emboli that go along with that. Patients die from pulmonary embolism when it is not picked up on. It's something you need to pay close attention to, particularly if you have a patient who's on bed rest or has a DVT. This is the pulmonary emboli highway from the memory book, talking about the mixed match between the VQ scan. This is pulmonary emboli again from the memory book, talking about risk factors in mobility, obesity, DVT, postpartum, postoperative, postpartum, or oral contraceptives. Okay, I'm going to go back to the previous slide because I don't like the look of this one. My dad died quite a while ago now, but he and my mother had been married for over 48 years at the time of his death, and so that was a big part of her life. And I would come home from work and find her sitting in a chair. I'd get up at night and find her sitting in a chair because the bed was too big. I would find her in the chair most of the time. Now, she'd get dressed in between times. She'd change clothes, and we'd eat, and she'd move around a lot, but she was basically very, very sedentary. And so I decided to take her out of the house because I figured she needed to get out of the house. And so we went to Frankenmuth. And for those of you who've been to Frankenmuth, Michigan, you know that it's hilly. And I walked her uphill and downhill and in and around and kept her moving and brought her home. And at 2 o'clock in the morning, she woke me up and said, "I think I'm going to die." Well, believe me, if your patient says you think they're going to die, you believe them and investigate further. I asked her why. She said, "I don't know. I just feel like I'm going to die." I said, "I'll call 911. She said, "No." I said, "Mom, we got to do something." She said, "Well, I'll go to your hospital." So I drove quite fast because I was working in Toledo and I live in Gibsonburg, and got her up to my hospital, which at that time was Riverside. It's not my fault it closed, but it was still active at that time. And I knew the ER doc, and I explained that my mother had been basically sedentary since my dad had died, and I think she was just deconditioned, but, I had walked her all over Frankenmuth, and he listened to her, and she sounded okay, and he did everything. He said, well, let's just, to play it safe, let's do some blood gases. So he did some arterial blood gases. Now, my mother has never smoked in her life, and her PaO2 was 58. Since the normal is 85 to 100, or 80 to 100, we knew something was wrong. So then she had a VQ scan, and it showed multiple emboli all over the lungs. And they did a Doppler study of her knee, and it showed a huge blood clot behind her right knee. So she was in the ICU unit for about 3 days, and then she was in the hospital for a total of about 10 days, and she went home on Coumadin for 6 months, and she didn't like any of that. So she would set her alarm and get up and walk every 2 hours so that she was no longer sedentary. Listen to your patients, because had I not listened to my mother, the emboli would have gotten worse. Pulmonary hypertension is an increase in pulmonary artery pressure by 5 to 10 millimeters of mercury. A pulmonary artery pressure is a very low pressure system. So an increased pressure here increases the workload of the heart. It makes the heart work a whole lot harder. Primary pulmonary hypertension is very rare. It is idiopathic. It has a very poor prognosis. It tends to occur more in females between 20 and 40. You have an HIV infection as a possibility. Collagen vascular disorders or use of appetite suppressants can all lead to pulmonary hypertension. But it does cause an increased workload of the right ventricle and cor pulmonale, which is right heart failure, due to lung problems. Symptoms are right heart failure and cyanosis. It is characterized by endothelial dysfunction with overproduction of your vasoconstrictors like endothelin and thromboxane A2. It causes a decreased production of your vasodilators, prostacyclin, and remodeling of your vascular smooth wall. So it causes fibrosis and thickening of the vessel wall with luminal narrowing and vasoconstriction. So the lumen gets very narrow and becomes vasoconstricted. Secondary pulmonary hypertension is due to diseases of the respiratory system that cause hypoxemia. And there's a figure on page 738 that talks about pulmonary hypertension. But you need to, I'll talk about that in a second. Some of the secondary causes of pulmonary hypertension are an increase in left ventricular filling pressure that occurs with coronary artery disease or mitral valve disease. A left to right shunt that occurs with a ventricular septal defect, a patent ductus, arteriosus. Obstruction of the pulmonary vascular bed that's due to pulmonary emboli or COPD. Vasoconstriction of the vascular bed that's due to hypoxemia or acidosis, and that's the usual cause. It results in hypertrophy of your medial smooth muscle layers of your arterioles and stiffening of your large arteries. So your pulmonary artery pressure raises to that of your systolic blood pressure, and since the normal is around 20/10, that's quite high. You end up in right ventricular failure and cor pulmonale. Initially, your symptoms are masked. They don't notice them. But then it'll show right ventricular hypertrophy on your electrocardiogram, fatigue, dyspnea on exertion, and just plain dyspnea will occur. They are using your drugs like Viagra to treat this because they're very potent vasodilators. So you may have some females getting Viagra for pulmonary hypertension. It does delay the onset of death. Cor pulmonale is also known as pulmonary heart disease. It is due to pulmonary hypertension and increased workload of the right ventricle. Symptoms are right ventricular hypertrophy, jugular vein distension, hepatosplenomegaly, so your liver and your spleen both get large, and peripheral edema. And this is looking at cor pulmonale, where you have lung disease that causes an increase in pulmonary vascular resistance and a decrease in oxygen supply. That decrease in oxygen supply causes right ventricular hypoxia, decreases the force of right ventricular contraction, increases right ventricular end diastolic pressure, preload in the right ventricle and the atrium, and so they end up with peripheral edema. increased oxygen demand. So cor pulmonale, lung disease due to heart problems. Yeah. Or, yeah, that's right. Cancer. Cancer of the lip is usually due to squamous cell carcinoma that causes the area to become thickened and ulcerated with a raised border. This tends to occur mainly in men, and particularly of the lower lip. Symptoms are a blister to a superficial ulceration. Laryngeal cancer is a squamous cell carcinoma of the glottis. Now, the glottis are your true vocal cords. This is the most common form. Symptoms are hoarseness, dyspnea, cough, maybe a sore throat, or maybe laryngeal pain. Risk factors are smoking, and smoking and alcohol combination, or the HPV virus, the human papilloma virus. Men between the ages of 50 and 75. They may also develop a small cell carcinoma with metastasis to the lymph nodes. Lung cancer, bronchogenic carcinoma of the epithelium and the respiratory tract. This is the most common cause of cancer deaths in this country. It still is. There's a 5-year survival rate of about 16%. Pathologically, the tar in cigarettes alters your p53 gene, which is your tumor suppressor gene, if you remember back from genetics. And this will, if it's not there, it will cause an increased growth of the cancer. That tobacco smoke also causes structural, functional, malignant, and toxic changes to the lungs. There are different types. Small cell carcinoma is an oat cell carcinoma. It has the strongest correlation with cigarettes. It stimulates your neuroendocrine cells, so that causes an increase in your antidiuretic hormone release and causes signs and symptoms of Cushing's. Small cell grows rapidly. It metastasizes early and widely. It has the worst prognosis, maybe 9 to 10 months once it's diagnosed. It causes 15 to 20% of all the types. If it's untreated, they survive maybe 1 to 3 months. If they are treated, 14% are alive after 2 years. The Cushing symptoms, in case you don't remember them from endocrine, are muscle weakness, facial edema, low potassium, alkalosis, hyperglycemia, hypertension, and increased pigmentation. The tobacco smoke contains over 30 carcinogens that cause 80 to 90% of all lung cancers. Mutation of the p53 gene occurs in 50 to 60% of non-small cell lung cancers and 90% of small cell lung cancer. Risk factors are smoking, secondhand smoke, COPD, genetic predisposition, occupational exposure, toxins, radiation, air pollution, and tuberculosis. Non-small cell carcinoma occurs 75 to 85% of the time, and it's associated with pneumonia and atelectasis. Squamous cell carcinoma is a non-cell carcinoma. It affects the hilus, the bronchi, results in obstruction and a non-productive cough. It rarely metastasizes occurs about 30% of the time. Chest pain is a late symptom. Adenocarcinoma, on the other hand, occurs 35 to 40% of the time, more in the peripheral regions of the lungs. The tumor will arise from the glands, and it tends to be asymptomatic initially, very slow growing, and it may metastasis, it may not. When it's advanced, you'll have shortness of breath and pleuritic chest pain. Large cell carcinoma, it's a large cell undifferentiated carcinoma, is a rapid growth. Early metastasis occurs about 15% of the time, more so in females, You're going to have an increased environmental occupational carcinogens that tend to work at that. Now keep in mind the general symptoms for everybody with lung cancer are chest pain, cough, pleural effusion, sputum, and weight loss. Weight loss is never an early symptom. And keep in mind that women have 2 copies of the gene GRPR, which causes your bronchial cells to proliferate, and that's why it's activated earlier in women, giving women the increased susceptibility to cancer. And women decided that if they're going to be equal with men, they're going to smoke also. So that's why lung cancer has been on the increase in women. And this is showing the different types of cancer. You've got your squamous cell carcinoma, upper left, small cell or oat cell carcinoma, upper right, which has the worst prognosis, and then the other 3 are your non-small cell carcinomas. Croup is an acute laryngotracheal bronchitis, so it affects your larynx and your trachea and your bronchial tree, and it's all inflammation. Tends to occur between the ages of 6 months to 5 years. Those who have a family history. It's due to the virus parainfluenza or influenza A or your RSV viruses. You'll have airway obstruction that occurs under the glottic region of the trachea, so it's below the vocal cords, and it often resolves on its own. Stridor will occur on inspiration and expiration, and that's due to the inflammation and the edema of the upper trachea. You'll have increased mucus production, rhinorrhea, sore throat, low-grade fever, and then a seal-like barking cough, if you've ever gone to SeaWorld and hear the seals cough, or to the zoo. And I can't demonstrate it. But this is showing acute laryngotracheal bronchitis, or croup, based on the memory book. You know, the crowing sounds or the stridor that occur. Acute epiglottitis is due to group A strep, and they have a vaccine for the H influenza. Tends to occur between ages 2 and 7. Symptoms are fever, inspiratory stridor, severe respiratory distress, they're anxious with a muffled voice, drooling, dysphagia, and if it's untreated, they die. So it needs to be treated, and they die because of a total occlusion of that respiratory area. It's associated with pneumonia, otitis, which is an ear infection, meningitis, septic arthritis, and cervical lymph node inflammation. And this is showing epiglottitis from the memory book, and as you can see, you're going to have acute respiratory obstruction that needs to be treated immediately. Respiratory distress of a newborn tends to occur with premature infants under the age of 28 weeks gestation. It's also known as hyaline membrane disease. Risk factors are males, those children who have C-section without labor, why I don't know, if you have a diabetic mother, prenatal asphyxia, or prematurity. Pathologically, you have surfactant deficiency and decreased alveolar surface area. Small, underdeveloped alveoli, the rib cage collapses inward with respiratory effort. They develop hypoxia, hypercapnia, atelectasis, vasoconstriction, shunting that decreases perfusion to the lung, causing right to left shunt. You'll have decreased pulmonary blood flow that shunts blood through the patent ductus arteriosus in the foramen ovale. You'll have increased pulmonary capillary permeability that causes plasma proteins to go into alveoli with fibrin deposits in air spaces, giving the appearance of a hyaline membrane. Symptoms occur within minutes of birth. Asphyxia, severe respiratory distress, tachypnea, they'll have respiratory rates in excess of 60, expiratory grunting, intercostal and subcostal retractions, nasal flaring, poor color, progressive hypoxemia and dyspnea, apnea and irregular respirations. If they survive, they can develop chronic obstructive pulmonary disease. Bronchiolitis is an inflammatory obstruction of the small airways or the bronchioles. It's most common in infants and toddlers due to the RSV. The viral infection causes necrosis of the bronchial epithelium and destruction of the ciliated epithelial cells. You'll have infiltration with lymphocytes and cell-mediated hypersensitivity. The submucosa edema and fibrin plugs form atelectasis with bronchial constriction, decreased lung compliance, hypoxemia, and a ventilation perfusion mismatch. Symptoms are rhinorrhea, which is a runny nose, tight cough, poor feeding, lethargy, fever, tachypnea, wheezing, crackles, rhonchi, atelectasis, particularly in the right upper lobe, and apnea that requires a ventilator. Bronchopulmonary dysplasia is also known as chronic lung disease of infancy. Pathologically, you'll have a disrupted lung development with poor formation of alveoli, a decrease in pulmonary capillaries, decrease in gas exchange, the ventilation perfusion mismatch, poor exercise capacity, and pulmonary hypertension. Risk factors are prematurity, positive pressure ventilation on the day of birth, supplemental oxygen, antenatal chorioamnionitis, or inflammation of the amniotic fluid, postnasal sepsis or pneumonia, patent ductus, nutrition deficiency, or adrenal insufficiency. Symptoms are hypoxemia, hypercapnia, tachypnea, decreased ability to feed, bronchospasm, and mucus plugging. They will have an increased incidence of asthma during childhood and a decreased ability to feed due to that increased work of breathing. Cystic fibrosis is an autosomal recessive gene disease that affects the chloride secretion in your airways, bile ducts, pancreas, sweat ducts, and vas deferens, causing mucus plugging, chronic inflammation, and infection. And the chronic inflammation becomes a vicious cycle, causing long-term lung damage and an increase in mucus production. It tends to occur more in whites and is diagnosed by about age 6 months to 1 year. Symptoms are dry, viscous mucus, so it's really thick, cough, wheeze, recurrent pneumonia, barrel chest, digital clubbing, meconium ileus at birth, and failure to thrive, malabsorption, pancreatic insufficiency, and hemoptysis. That malabsorption is evidenced by frequent, loose, oily stools. Children with cystic fibrosis used to die easily by the age of 20. They're now surviving to 40 and longer. There's a figure on page 761 you need to look at. Now, meconium ileus is you have an intestinal obstruction that's caused by meconium, which is the first stool, that sticks to the ileum due to the lack of the digestive enzymes during fetal life. It contains albumin, and it can be used to screen for cystic fibrosis. The terminal ileum becomes plugged. Symptoms are abdominal distension, vomiting, and dilated intestinal loops that feel like dough when like you're making bread. It's on page 988 to 9 in your textbook. And the impaired digestion is due to a pancreatic enzyme deficiency that causes maldigestion. And we can give those exogenously now. The mucus production will block the flow of enzymes. There's a table on page 993 that talks about all the symptoms for cystic fibrosis. You'll want to look at that. And this is a flow chart showing the cystic fibrosis effects, basically, and what causes them. And here again we have somebody with cystic fibrosis who has talking about the treatment on the left and the symptoms on the right. And finally, sudden infant death. SIDS. SIDS has an unknown cause of death in infants under 1 year of age that is unexplained even when it's investigated. Risk factors are to be 3 to 4 months of age. Didn't spell months right, left out the age. Men, boys more than girls. Nighttime, more so in the winter. If they're preterm or low birth weight, if they're a sibling of a prior SIDS child, if the child is in the prone position, if they're on a soft surface, if you overheat the room, or overwrap the infant. Risk factors are maternal smoking, being under the age of 20 when you had your child, poverty, and little prenatal care, or if you're taking drugs. The program of putting your child back to sleep or laying them on their back has decreased the death rate anywhere from 40 to 70%. But it's something that still needs to be taught. That finishes the respiratory lecture. Thank you.